Hello and welcome to EJC News Focus. Innovation was everywhere at the European Cancer Congress in Vienna. But the keynote lecture by Nazneen Rahman from London was a call for implementation of existing knowledge on germline genetics. Screening the DNA of patients' normal tissue could be easily done, she said, but it's too rarely part of routine care.
Our aspiration is for any cancer patient that can benefit from germline genetic testing to have an opportunity to access that testing. Currently, the processes are very complicated and laborious in order to access that testing. What we want to do and what we've been doing is to get that testing as part of the routine cancer patient pathway.
Why isn't this happening?
I think 20 years ago when we found these genes initially, because it was so difficult to test them and it took a long time, a whole set of infrastructure set up effectively to limit testing because we didn't have much capacity, and they were very laborious and had very sort of stringent criteria that made it difficult to access testing. Now we want the complete reverse. Now it's cheap and quick and easy to do testing, but the processes to access the testing are incredibly expensive because they involve people checking things and all sorts of things that we no longer need. So we need both conceptual and sort of people to sort of understand the reasons for the change, because often over time you forget why you initially did it. You just do it because that's the way you've always done it. So we need to sort of have some sort of change of mindset as well.
How is this different from what's happening in routine care?
On one level, it's not different at all. It's all the same things that we've been doing, all the same standards, all the same kind of robustness. It's just a sort of switch of that in terms of rather than just making it much more easily accessible to patients. A lot of the sort of complicated conversations that we used to have because we were talking to people who may or may not have a future risk of cancer really don't apply in the context of somebody who's got cancer and is wanting that information first and foremost to decide how best they should be treated. That's kind of normal cancer medicine. So we have to integrate that into the normal cancer medical pathway. But we've found over the last year or so when we've been doing it that that's happened very quickly, very rapidly. Once people understand that we're asking them to just do kind of normal medicine and we're doing it in this context, and any of the complicated information for relatives and unaffected individuals will be taken on by the specialised services, then actually we found that it's been very, very straightforward to implement.
So could you talk us through the work you're doing in ovarian cancer?
Well, ovarian cancer is probably one of the most important cancers to do in this way, because a large proportion of ovarian cancers are due to these germline mutations. 15% of them are due to mutations in two genes alone, BRCA1 and BRCA2. So what we've done is to get that testing into the routine oncology clinics so that when a woman has been diagnosed with ovarian cancer, her cancer doctor would be able to say to her, well, we know that about 15% of these can be due to the BRCA mutations. We can offer you a test that will allow us to decide on the best treatment for you, and it will also give more information for your family.
How acceptable was it to patients?
We were surprised because actually when we started off in this pilot study, about 200 patients came through that we offered the test through this what we call mainstreaming process, the cancer doctors directly asking them, and all of them accepted it. And all of them said, yes, that sounds like a good idea, thank you, really pretty quickly. And afterwards we went back and asked them how they felt about it afterwards, and all of them were pleased they had the test, irrespective of whether there was a mutation or not.
You're saying that ovarian cancer patients who are BRCA positive represent a failure of prevention?
We've known about the BRCA genes for 20 years, and we've known that they cause a significant proportion of ovarian cancer. Studies typically show 10 to 15%, but that proportion has stayed stable. In our recent study, it was 15% that had the BRCA mutation. So many women who have got a BRCA mutation will elect to have their ovaries removed after they've completed their families. And yet, We've so far had a stable amount of ovarian cancer due to the BRCA genes, so that suggests that we're just not identifying enough of these BRCA mutations, and so we've not offered enough women the opportunity to do that prevention. And we know that's true because we know very few people were getting this testing before, but that's what it's a failure of prevention. In the UK, 1,500 women will have ovarian cancer due to BRCA every year. Each one of those could be, in theory, prevented, so we need to make more of those prevented.
So that's the challenge from Nazneen Rahman. And with thanks to her, that's it for this month's EJC News Focus.